So now I'd like to turn it over to your co-host today. We have Jessica Corcoran. She is the Executive Director for the Erdheim-Chester Disease Global Alliance. And we have Deanna Fournier, the Executive Director for the Histiocytosis Association.
Thank you, Kristen. We're very happy to have everyone on today. We are looking forward to hearing from the experts on eye care, and I know you are also. Please keep track of your questions and ask them at the end. And like Kristen said, we'll do our best to get to those questions. And we will have our contact information at the end of the meeting as well, should you need anything further. So I just want to just extend my gratitude to both Dr. Francis and Dr. Diamond for giving up their time today. They have seen an extensive amount of patients, and I know they can help you out with your eye care needs. And we have been enjoying our partnership with the Histiocytosis Association. Deanna and Kristen and their entire team has been fantastic, and we really enjoy doing these webinars with them. So keep looking for these, and we'll continue to try to offer this to you guys. So I will turn it over to Deanna.
Thank you, Jessie. Thank you, Kristen. And just to echo what Jessie said, we're so grateful for the partnership of the Erdheim-Chester Disease Global Alliance as we work together to provide the best resources for the ECD and Histio community. So I'm going to introduce our hosts for you today. As Jessie mentioned, we have two very esteemed physicians from Memorial Sloan Kettering in New York City. We have Dr. Jasmine Francis and Dr. Eli Diamond, and I'll be taking you through the webinar for today. And like we mentioned at the end, there'll be contact information as well, should you need anything at all. Thank you so much, and I'll turn it over to our hosts.
Good afternoon, everyone. I'm Jasmine Francis. Eli Diamond is also here. We are colleagues together at Memorial Sloan Kettering, and we would certainly like to thank Deanna, Jessie, and Kristen for putting this together. And I hope you will find this interesting and useful. We have no financial interests or commercial relationships. We may be describing the off-label use of drugs, and any images that we show here are either publicly available or patients have given us permission to share these photographs with you. To start with the basics, which many of you are already aware of, histiocytosis can be largely divided into two groups, so Langerhans cell and non-Langerhans cell, of which ECD is an example. And there are various parts of the body that can be involved with these two disease entities. So both can involve the skin and the bones. They may differ a little bit. So the Langerhans cell is more likely to involve the spleen, the liver, and the lymph nodes, whereas non-LCH is more likely to involve the orbit, which are the structures around the eye, which we will get to, the maxillary sinus, which is pretty close to the orbit, and the heart. And then both again can involve the CNS or the brain, and can also involve the lung, although there are some differences to how frequently each is involved in Langerhans cell versus non-LCH. To quote Helen Keller, the only thing worse than being blind is having sight but no vision. What we'd like to do today is to divide our talk into two different sections. The first is to describe how histiocytosis can affect the eyes and vision, and then also to touch on how treatment can also affect the eyes and vision. And we will start by talking about the disease itself. This is a scenario that patients have been asked to answer, and so we'd like to talk through this and this scenario, and we'd like you to imagine what your answer might be to this question. So suppose there was a technology that guaranteed your vision will return to normal. So you have to imagine that your vision is not normal. And this technology always works, but it does decrease your survival. And the question is, what is the maximum number of years, if any, you would be willing to give up to have normal vision for the remainder of your life? And the reason why doctors have used this question is to help us understand and gauge how important vision is to our patients. So let's see what patients have said in the past. If we look at patients who have vision which is not normal vision, but it's good enough where they can still legally drive, about 20% of those patients, sorry, to say it a different way, patients on average would give up 20% of their survival to have normal vision. And that's similar to patients who are living with AIDS. 20% of them would be willing to give up 20% of their life to have a normal life. And what about patients who are legally blind? These are patients who cannot see the top letter E on the eye chart, and on average they would give up 50% of their survival to have normal vision. And that's similar to patients who've had a stroke and are unable to walk without assistance. And then finally, there are those patients who are truly blind, meaning that they cannot appreciate or see light. And those patients on average would give up 60% of their survival to have normal vision, which is similar to patients who have a stroke and are bedridden. And so what this tells us as doctors and as physicians and care providers is that vision is very important to patients. And it's on the basis of this that we want to help you, and we want to tell you more about how we think the disease and the treatment may not only affect your vision, but also might help your vision. So we're going to talk about the eye, and we think the easiest way to do this is with the anatomy of the eye. So we'll start with the front part of the eye and sort of work our way back. So we'll start by talking about the eyelids. Here, I don't know if you can see my, my arrow, but here is an eyelid. And for histiocytosis, very commonly, patients will have what we call xanthelasma, which are these raised yellow areas on the eyelids. They are usually in the corners closest to the nose, although they really can occur kind of all around the eyelid, both on the upper and the lower lid. They usually don't hurt. They can be obvious in some situations, but not obvious in others. They are not dangerous and they can be observed. But what is very useful about these lesions is that they are a very good site for us to biopsy, a good site to biopsy because it's relatively safe, but also it can be very rich with useful information that might allow us to guide treatment. So these lesions can give us information about the genetic abnormalities that are present in the histiocytosis, and that might guide the best way to treat you. I'd like to show you a photograph of what it looks like after we've biopsied this. I don't think it's too gory. I don't think I would give it an R rating, but I do want to warn everybody that I will be showing you another photograph. Here is about 2 weeks after having removed this xanthelasma, and you can see that there is a stitch here, a suture, which will be removed, and then after about a month, you can see the eyelid is healed up nicely. You can just appreciate a very faint scar here, and it has no impact on vision and no impact on the appearance of the eyelid, except that now that yellow bump has gone. All right, so moving on back, to the orbit. So the orbit, I like to describe this as everything but the eyeball. So there is a bony cave surrounding the eye, and then there are soft tissues around that. To give you a better example of that, here is a photograph of a part of a bony skull. So this is an orbit. You can see it's made up of bone, and the eye sits in this bony cave just like that. And histiocytosis very commonly can accumulate within this bony cave, as I'm showing you here with the yellow plasticine. And then the eye has to try and fit in that. So you can imagine that when you have this histiocytosis sitting in this bony cave, it can push the eye out, so it looks like it's protruding. It can impact the way that the muscles work around the eye. And if that happens, then the eye might not move quite as well, and patients can get double vision. It can change the way that the eyelids look. So the eyelids can sometimes look droopy and sometimes there can be puffiness. The other thing that we want to point out is that the eye communicates with the brain through this, what I'm showing you here with my moving arrow. This is the nerve. I think of it almost like the cable between the eye and the brain, and it sits in this bony cave, and then you can see that little slot at the back there. That nerve has to fit through that hole to communicate with the brain. And you can imagine that if you have histiocytosis disease in this orbit, then that can push on the nerve and starve it of oxygen. And if that happens, then you can have a problem with the nerve and that can affect your vision. So on that note, let's talk about the nerve of the eye. This is what a nerve looks like when you look directly into an eye. This is as though you've taken a hot dog and you've cut it in half, and now you're looking at the circular portion. And what I'd like you to take note of here is that the nerve looks pink and the blood vessels, you have to take my word for it, but they look healthy here. Just next to it, I'm showing you this sort of cross that has these tiny black dots with a white surrounding. And this is an example of what a normal visual field is like. A visual field is your normal field of view, so it's what you see all around you. And if you have a tiny little black dot there that's surrounded by white, it means that you're able to see everything that's there. When the nerve is damaged, you can see there that the nerve has become less pink. It's more white, it's pale, and the blood vessels have kind of been nudged over to one side. When the nerve is damaged like that, it does affect your field of view, so that now you have these blacked out dots or squares. And when it's blacked out like that, this it shows an area where you're not seeing. So it's like you have a blind spot everywhere that there's one of these black dots. So it means that your field of view has become very small and is just that little slither that I'm showing you here. So going back to disease in the orbit, I'd like to show you, here is an example of somebody that has disease in their orbit. This is an MRI image, and I'm going to outline for you where the disease is. And in this particular instance, or in some instances in general, we may treat this by giving patients steroids, and that can be a temporary way of decreasing the disease and putting less pressure on the nerve so that patients don't lose vision. And there are, as many of you may be aware, there are targeted agents that we can use, which can be effective, but they can have other side effects to the rest of the body. And so if that is not an option for a patient, then very often we are searching for another way of treating these very localized, isolated sites of disease. And so in this particular instance, we did something that is new to the field, that at our center at Memorial Sloan Kettering, we have used for other diseases. But let me walk you through what we did. So we took a very thin tube that we placed in the artery at the top of the leg, and we snaked that tube through the aorta, which goes through the heart, and then into one of the blood vessels in the neck. And then we take the first highway, which is the only artery that goes towards the eye, and we injected little drops of drug into that artery. We then did that to a couple of other arteries as well. And to give you sort of a reference point, we literally gave drops of drug, upwards of about 2 teaspoons of drug, which is equivalent to the amount of Tylenol that you might give to a 2-year-old that has a fever. And if you look down here back at this MRI image, I'm going to show you what happened to the disease after the treatment. You can see that it just melted away, and all that we're left with here are the normal muscles around the eye that help the eye move. And you can see here that there's a healthy nerve. And so this patient went from a vision of only barely being able to see light to then having 20/20 normal vision. Let's now talk about the surface of the eye. So this refers to the conjunctiva, the cornea. The cornea is where you would put a contact lens, and then the episclera and sclera. And here is the plastic eye that shows you the yellow histiocytosis as a way of referencing where the disease is that we're talking about. Here down below is an example of disease which is just under the conjunctiva, and here's an example of where it's now creeping over onto the cornea, which is that clear dome, again, where you put a contact lens. And when patients have disease in this location, their eye can look red, it can feel uncomfortable, they can describe a hot sensation, a pricking sensation, typically localized to the eye, but sometimes it can kind of radiate up and around as though you have a headache behind the eye. There are other things that can give you this symptom, so it's not only disease in this location that would give you that feeling. And the mainstay way that we treat this is to treat the underlying cause, which in this scenario would be treatment for the histiocytosis in the rest of the body. And that can do a remarkable job at treating what is on the eye. If patients need a little bit more help with the eye, then we can also give them the equivalent of liquid Advil eye drops, or a steroid eye drop as well. I'm showing you here down below at the bottom right-hand corner, you can see there on the white part of the eye, it's pink. And after this patient started systemic treatment, it just cleared up, and the symptoms of redness and discomfort went away as the disease was treated. Let's talk about an area of the eye that we call the anterior chamber, and also the lens of the eye. So the anterior chamber is behind that clear dome, the cornea, but it's in front of the iris. And this is a part of the eye that's filled with the equivalent of water. And in histiocytosis, sometimes this little water chamber can fill up with histiocytosis, or what we refer to as little cells of inflammation. And the name that we give that is iritis or uveitis. And when patients have this, they can get pain in the eye, they can get sensitivity to light, the eye can look red, and sometimes it can affect the vision as well. The main way that we treat uveitis is, again, to treat the underlying cause. So it's to give systemic treatment for the histiocytosis, but sometimes we'll give topical, eye drops of steroids, or possibly even an injection of steroids around the eye. There's a very useful drop, which is written here as cycloplegic. This is a drop that dilates the pupil, which can be a little bit annoying, but at the same time as dilating the pupil, it relaxes one of the muscles in the eye, and it can make the pain in the eye much better. And the time that we tend to use this drop is when patients have specifically this uveitis. Here is a patient that had uveitis. You can see that the uveitis, or the inflammatory cells in that part of the eye, have actually changed the shape of the iris because of scar tissue. And then after this was treated, the pupil went back to its normal round shape. Now we're going to skip to the back part of the eye, so the retina and the choroid. And I'm going to show you a few more images just to help you appreciate what part of the eye this is. So you can imagine it's almost like we've taken wallpaper and plastered it on the inside of the eye, and that's what the retina and the choroid are. So you can see as I'm bringing this around, What we do in the office is to use our instruments to look through the pupil. So you can imagine flying through the pupil, and this is the view that we get. This allows us to see the nerve of the eye and also allows us to see the blood vessels. And right here, this darker spot, which is the very center of the vision, which allows you to see clearly. These little black dots are just on the camera and they're nothing. This actually happens to be my eye, and you can see the eyelashes there. We then use imaging, cross-sectional imaging of the retina, and this can be very, very useful to us. And I certainly encourage any patient that is seeing an eye doctor to not to say no to having this type of imaging, because it really does give us a lot of information about the eye. So you can imagine this is a cross-sectional image. This is like we take a sponge cake, we cut it in half, and we're looking at sponge filling sponge. And what you're seeing down below there is all the 9 layers of the retina sandwiched on top of each other. And then right where it dips down is the center of the vision, or the fovea. Now, if there is any abnormality in the retina, then patients can have very specific types of symptoms. So here I'm showing you a grid. The normal grid area is what a normal eye would see. But if there is a problem with the retina, then patients might see a warping of those lines. We refer to that as metamorphopsia. Or they may have an area in their vision that is simply missing, or a blind spot, and we call that a scotoma. Let's go back to our plastic eye. So we've now opened it up. We're looking inside the eye, and here you can see that the retina is that clear layer that will fit inside like wallpaper, and underneath it is the orange layer, or the choroid. In histiocytosis, what we recognize is that the histiocytosis can accumulate, can build up in that orange layer, and then the retina fits over it like I'm showing you here. Now, very often patients will have this and have no knowledge that they have it because they don't get symptoms. But sometimes when there is histiocytosis in the choroid, it can push up on the retina and it can give symptoms of blurriness, or the kind of warping of the vision, the distortion of the vision that I showed before. Here is the cross-sectional image showing this bump. The bump under the retina is the histiocytosis. And when patients start their systemic treatment, so this is not treating the eye, this is treating the whole body, we can see that the bump flattens out and the retina goes back down into its normal position. And so if this is affecting vision, it now no longer will affect vision. We're going to tell you a little bit more now.
So I'm just going to talk for a couple minutes about how histiocytosis and the brain can affect vision, because there can be effects upon vision even if you are not directly involving the eye. So the eyes are kept in alignment by many different small muscles that pull the eyes from different directions. And if you look at that picture on the bottom right, those are all of the different what are called the extraocular muscles that keep the eyes moving in the direction that we want. And those muscles are themselves controlled by this whole network of nerves, and that's the yellow. And those nerves themselves come from the lower part of the brain, or the brainstem. So if you have a tumor or an abnormality anywhere in that pathway, such as in the brain or in the nerves, then what can happen is your eyes will not be aligned. And our brain really depends on those eyes being aligned to see one image. So this is an image of a patient with this tumor in the lower part of the brain, which is interrupting just one of those nerves. And if you imagine this person looking to the right, the eyes are aligned. But if they look to the left, one eye cannot go outward. And so this is what we would call disconjugate gaze. The eyes are not aligned, and this person would see double in that instance. Jasmine alluded to this earlier, but the vision goes from the eye to the optic nerves and then actually travels through this complex pathway into the brain. And if you have a histiocytosis tumor anywhere in this pathway, it can interrupt vision. Because particularly Erdheim-Chester and Langerhans can affect the pituitary, very large pituitary tumors can actually press on the back of the optic nerve where those two optic nerves cross. And that can lead to blurry vision or even more severe visual loss. So there's one example here. This is a histiocytosis lesion, which is, coming from the pituitary stalk, which is, has some significant size to it. And this person had blurry vision, but just to show a difference, another patient had a much larger tumor, and that was causing more constriction on the optic nerves, and that person experienced, very severe visual loss. So, to put it together, when we have someone with involvement of the eye, we take into account lots of different factors, and whether someone can have treatment just to the eye or the orbit itself, or whether we would do what we call systemic treatment, meaning treating the whole body. So local treatments would be something like surgery, which is often not done unless someone needs the bulk of a tumor to be reduced very urgently, or if surgery is needed to get tissue for diagnosis. Another local treatment is radiation, which does have a role for some conditions in some patients, depending on the instance. Sometimes patients can get injections of things like steroids into individual tumors that are causing symptoms. Jasmine mentioned intraarterial chemotherapy, which is this new treatment that we have been pioneering at MSK. Systemic treatments, something either given as a pill or into the IV, that would be chemotherapy or some of the gene targeting therapies. So things that influence this decision are, what is the extent of the disease? If someone has multiple areas of disease apart from the eye, likely that person will need treatment to the whole body, and the eye will benefit at the same time. How severe the disease is, which particular subtype of histiocytosis are we talking about, and how those will respond to different kinds of treatment. Then there's the dimension of people's medical history and other problems, and would those render someone, at risk from other complications from a different kind of treatment? This is all part of the bigger picture that has to be considered. And then, of course, what can we do to intervene to improve symptoms and quality of life? So those are the kinds of things that we think about when we're treating involvement of the eye.
Alrighty, now moving on to how treatment itself can affect the eyes and vision. And we do want to mention that there are benefits for patients to be monitored by an ophthalmologist, either because they have disease in their eyes or because they may be on a treatment that could potentially impact their eyes. And in general, we do recommend that patients, irrespective of whether they have histiocytosis or not, be evaluated by an ophthalmologist once a year. And it does make sense that if there is an ophthalmologist who is familiar with histiocytosis, that be the person who checks your eyes and your vision. And then as I go through these slides, which will show you some of the treatment effects of the visual effects of the treatment, I do want to mention that many of these are dose dependent. What that means is that the higher the dose of drug that you get, the more likely you are to have these side effects. So having said that, a cataract is where the lens of the eye, the lens is very similar to a clear lens that you would have in a camera that allows the camera to focus. And a cataract is when that clear lens becomes yellow, white, or milky. And that means that instead of having a clear view, your view out of the eye is blurry, there can be glare, it just doesn't feel quite right. Although I do want to point out that this is thankfully painless. These can be accelerated by the use of steroids, but again, it is dependent upon how many or how long the steroids are. So what I like to tell patients is if you use 1 drop of steroid every hour, every day for 2 years, then that can accelerate the onset of a cataract. But if you're using steroids less often than that, then it's unlikely that it would make a big impact on a cataract. And then the other would be radiation. And this is really in the scenario where you're getting direct radiation to the eye. If you're getting radiation elsewhere, it's unlikely to affect the eye. Cataracts, thankfully, are very easy to reverse. There is approximately a 30-minute outpatient, meaning you go home the same day, surgery that can remove the cataract and improve vision. Cystoid macular edema, this refers to having swelling in the retina. So up above here, you see a normal retina, the same image that I showed you earlier. And then down below here, you can see these kind of black oval areas within the retina. And this is fluid, which is distorting and changing the shape of the retina. And when it does that, it can make the vision blurry and can make the image look distorted. BRAF inhibitors, which is sometimes used as treatment for the whole body, in about 4% of patients can give you this. And the way that we would treat it is either with steroid drops or with an Advil, liquid Advil type drop. Sometimes we might offer an injection into the eye with the same medication that's used to treat macular degeneration. That can be helpful. And then there is another type of medication, which I like to describe it as a drug that sort of dries you out. And in doing so, it sort of dehydrates you, but at the same time, it dehydrates and removes the fluid from the retina. It's also possible with some treatments to get fluid under the retina. So up above, I'm showing you normal as a reference. And now if we skip to the image down below, you can see this kind of black dome, and that is fluid that is under the retina. And when there's fluid under the retina like this, it can make the vision blurry, it can distort the vision. Patients have described that when they have this, they feel that when they look at objects, there is sort of an orange glow around objects. And patients describe that their perception of color, their ability to see color seems off. It sort of feels like the color is faded. MEK inhibitors are probably, of what I'm showing you here, are the most common to give these bubbles of fluid under the retina. But I do want to emphasize that only 15% of patients, 15%, will develop these bubbles of fluid. But on the dose that patients with histiocytosis take of MEK inhibitors, that number is even lower. So less than 15% will develop these bubbles of fluid. And the key thing to keep in mind is that if these bubbles of fluid do appear in the retina, only half the patients have symptoms from them, which tells us the symptoms are pretty mild. And there is no need to come off the drug. So you can remain on the MEK inhibitor. And over time, these bubbles of fluid will just dry up on their own, even when you remain on the drug. I will briefly mention that steroids, when given to a small group of patients, can give fluid under the retina, which is shown in this middle image, and that one may be less reversible. Most of the time it can be reversed, but there is a small possibility that it would not be. MEK inhibitors, extremely rarely, again, I'm emphasizing very, very unlikely, but they can block one of the blood vessels of the eye. And if this happens, then patients can have a painless change in their vision. When you have this blockage of the blood vessel in any scenario, not related to treatment, it is sometimes difficult for us to reverse the vision. However, in the handful of patients that I've seen that have had a blockage of one of the blood vessels in their retina from a MEK inhibitor, we were able to reverse everybody's vision back to what they had beforehand. And we did that with a combination of giving the eye time to heal and giving injections of medication into the eye. We believe that the risk of this happening when on a MEK inhibitor is less than 0.3%. So again, a very, very small risk. And here is just an example of how the eye can reverse back to normal. So here you see that it looks very thick, the retina, and then after time and injections into the eye, not only does the vision improve, but the appearance of the retina also improves. And then just a quick note, we talked about the nerve a couple of times already, but to note that sometimes treatments can also affect the nerve. And examples of that are that in 5% of patients who take a steroid drop or a steroid pill, they can have an increase in the pressure of their eye, and that pressure has the potential to affect their nerve. That usually happens over the course of weeks or months. So it's not an immediate effect, but this is a good reason for getting your eyes checked, because the pressure can be high in the eye and you may have no symptoms that you have high pressure. And with a simple eye exam, the pressure can be checked and eye drops can be given that help to lower the pressure and reduce the risk of having damage to the nerve and to vision. So in summary, there's a wide variety of histiocytosis and treatment effects on both the eyes and vision. We do believe it's important to be evaluated by a team who's familiar with histiocytosis and their subtypes, both the common and the rare manifestations. And we've touched on some of the new treatments, which are very promising. But in the context of taking one of these new treatments, we do recommend that an ophthalmologist be involved in the care of your eyes and your vision. And if you wanted to learn more about our center and specifically our treatment of histiocytosis, I'm leaving that URL up there for you. Eli, shall we look at the Q&A or the chat?
Yeah, sure. So I'll start. I see a question. This was about some of the earlier disease manifestations you were talking about, Jasmine, I think with like the lens and the retina. Would this eye disease show on a PET scan, brain MRI, or would it only show on an eye exam? So PET scans really need for something to be about 1 centimeter to show up, and MRIs have better accuracy, but apart from a very bulky lesion, in the orbit, much of what Jasmine described with the choroid and the retina and the front of the eye would only be seen with an eye exam from an ophthalmologist and would not show up on a scan.
Very true. And some of these, for instance, the uveitis, which can really be bothersome and if left untreated can pose a problem, that really can only be seen with the instruments that we use in our office because the size of the disease is just so tiny.
Do you see the second question, Jasmine?
Hold on, let me take a look.
Oh, you have your screen up. So yeah. I can read it. Okay. If you had a treatment a year ago that could affect the eye, how long is it a possibility after the treatment is complete? So I think that really depends on what kind of treatment you're talking about. For things like BRAF and MEK inhibitors, I wouldn't expect there to be eye effects if you've completed that treatment, a year prior. Something, in an opposite way, radiation could have a delayed effect on the eye if that's the treatment being talked about. Now, Jasmine, you want to add anything to that?
Yeah, so for radiation in general, again, it does depend upon how much radiation is given, but in general, the most common time to have the effects is at 18 months after the radiation. For BRAF inhibitors, for MEK inhibitors, once you're off the drug, there really should not pose a problem if one is off the drug. And very often those bubbles of fluid that we saw, or the fluid that's within the retina, typically occurs in the first 3 months of treatment, but it can occur in a delayed way. I think we have an unusual scenario of patients where it doesn't occur until they've been on the drug for a year or later, but that is less likely. It's more likely to show itself in the first 3 months.
And then another question, would any of the treatments outlined be beneficial to someone with ECD who has been blind for years from optic nerve involvement?
So optic nerve involvement of disease is very difficult for us to treat. It really depends upon how the nerves have been affected. In many instances, when disease or for whatever reason the nerves have been damaged, it's difficult for us to reverse the function of the nerve. So it's difficult for us to, once the nerves no longer see vision, it's difficult for us to bring vision back if it's been a long period of time. But we do know that if the disease is active and is actively affecting the nerves and we treat the disease, then we can get vision back. So it's a combination, it's difficult to answer, but it's a combination of how much disease is involved, how long the nerve has been damaged, and how active the disease is.
While on a MEK inhibitor, how often should the patient be seen by an ophthalmologist?
I would recommend being seen in the first month and again in the first 3 months. So 2 kind of visits in the first 3 months. And if there's no evidence of bubbles of fluid at that point, then a 6-month follow-up, I think, would be reasonable.
That's all I'm seeing for the questions.
Okay.
Do you guys from the ECD, GA, or Histio teams want to wrap up?
If you have any more questions, please go ahead and add them now, or you can email our team later. You can email us directly at the ECD, GA, or the HA, or directly to Dr. Diamond or Dr. Francis. We will be sending out an email with the recording, along with the slides we'll be showing in the recording. And we also attach information that is available to patients for clinical trials. So keep watching for that. Next slide. There's our contact information. If you wanted to copy any of that, you can, but again, we will be sending all of this in your emails. We will also add resources that you can find on the Erdheim-Chester Disease Global Alliance website, and more information about the patient registry can be found there as well if you follow our links. And on our next slide, we'll be adding information about the Histio resources for all the types of histiocytosis, so that you can reach out to either one of us in the community forums or on our website or chats on any other web-based services that we have. So just reach out in any way you need to, and we hope you stay in touch and join us on our next webinar. We do have one more question from John.
Jasmine, can you see that question?
I can't, no, I can end this and then I should be able to, no, I can't see it.
Okay, I think it may be tough to answer. I have a red area in the bottom left of my eye that comes every 1 to 3 months, lasts for a few days. I do suffer from dry eyes. So I think that may be tough. Dry eyes is a very common side effect, I believe, of certainly MEK inhibitors and maybe some of the other treatments also. Something that's disease related may be less likely to come and go, for days at a time. But I'll let Jasmine.
Yeah, so a red eye is certainly a very good thing to see an ophthalmologist about. The majority of the time, the people have a red eye. As Eli mentioned, it's due to dryness, and there are so many reasons to have dry eyes. It's like having dry skin on your hands. It's very bothersome, but there are ways that you can make it better and make it feel better. But it is worthwhile seeing an eye specialist who can check the eye, because there are other reasons why you can get redness, such as inflammation. And in a patient who has histiocytosis, it's important to make sure that it's not actually disease and that it's not related to treatment.
Thank you very much. This was a very interesting webinar, and we thank you both for hosting and sharing your knowledge with us. Deanna, do you have anything else to add?
I just want to also express gratitude to Dr. Francis and Dr. Diamond. This was very interesting and provided a lot of resources that we can share with the community. So thank you so much, and thank you to the ECD Global Alliance for this partnership.